Hello, everybody. Now we're honored to have Professor Mynzhylky, a consultant neurosurgeon from the National Hospital of Almaty in Kazakhstan. How are you doing, Professor?
I'm okay. Assalamu alaikum.
Alaikum salam wa rahmatullahi wa barakatuh. Welcome to the second annual conference of Easter. How do you find the conference so far?
It's a quite nice conference. We have friends with Ahmed El Serbi, and he just called me months ago and invited for the conference. But I'm following Ahmed on the social media, on Facebook and Instagram.
Perfect.
And I have seen a lot of support from the Ministry of Healthcare, from the government, and it's very noticeable. And yesterday the Ministry of Healthcare came for the conference and did a speech. And as I know, it's a radiological society, but the chief of the society is supporting the neurointerventions.
Of course.
And Ahmed also mentioned that the Ministry of Healthcare start to support more the treatment of the stroke.
Absolutely, yes, that's true.
It's very nice. How
did you come to know Dr. Ahmed El-Serbi?
During the conferences, we have a friend, René Chapeau, in Essen, in Germany. And during the ALIS conference in Essen, I think we introduced to each other.
He introduced you to each other.
And Ahmed came first time to Kazakhstan for the Neuro-Addict conference, which is international, in 2019. And then the last visit was in 2024.
Okay, perfect. Can you tell us more about Kazakhstan? I've never been there, but I've always wondered.
It's quite far from the Egypt, but you know the one of the famous Kazakh person, but at that time it was not the Kazakhstan, it was a land of nomads, and the person's name is Sultan Beybars.
Oh, of course.
Yes. He's Kipchak, he's from the region I was born. I was born in Kızıldağ. Kızıldağ previously was the region of nomads, Saks, and the Princess Tomiris was also there.
Excellent.
It's on the river Sirdarya and near the Aral Sea.
Okay.
And Kazakhstan has the ninth point of the territory in the world.
Okay. The highest,
number
the ninth
is
highest?
6 is Australia.
Okay.
You can compare.
Okay. Wow.
Yes, the highest part, and we have no way to the ocean, but we have a Caspian Sea.
Okay. Yeah. Sure.
And the Aral Sea was before, but it was shrinked, and now it became New Aral Sea, and we have part of Tian Mountains, which is the part of Himalaya.
Yeah, of course.
And the highest part of the mountains is 5.5 thousand meters.
Wow. Okay. Interesting.
Yes, we have ski resorts, we have desert.
You do a lot of skiing in Kazakhstan?
Yes,
okay.
We do skiing.
Yeah.
My children are skiing. And also, the Kazakh people has a history of nomads, has a history of Sak period, and then in 9th century, Islam start to come, and we moved to Muslim culture.
Okay. Is it, as far as I understand, it's mainly a Muslim country,
it's
isn't it?
Main religion in the country, but is democratic way of spreading the Islam.
That's fine. That's totally fine. Is this your first time to Egypt?
Oh no, I have been to Egypt first time in 2023, I think. We came to Sharm and at the same time we visited Cairo. The driver said the distance is 3 hours.
Yeah, between Sharm el-Sheikh and Cairo.
They lied.
No, it's not.
A lot of cardons, and
Yeah,
finally we did in 9 hours. I was with the family, my small daughter at that time, and we visited the old museum, Museum of Civilization, and also the pyramids.
Pyramids, of course. Yeah, you must have. And what do you think of them?
It's very interesting. On the books, it looks smaller.
On the books, it looks smaller.
On the photo, on the books, it looks smaller.
Okay.
And it's incredible.
Yeah, they are. It's nice that you have been. Is this your first conference to attend in Egypt?
In Egypt, yes.
Okay.
It's my second time in Cairo, and 3 times I have been to Sharm. And it's different. The Sharm is more modern and more international.
That's true.
And the Cairo, it's also mixed. There are old city, Giza, and
the more modern,
Cairo,
flashy
modern
places.
Cairo,
yes, you can have these places as well. Okay. And what do you think of the conference so far?
It's well organized, but as usual, like in our country, in Asian countries, in south-located countries, all the time delay.
Yeah, of course.
30 minutes, it's okay.
Yeah, okay.
Yes.
So you're you know this. You know that everything is a bit delayed.
Culture of delaying.
Yeah,
but it's okay. And
I believe it has a term, the Asian sense of time.
Yes.
Yeah.
Yes. And also the young physicians, they're more interested in new technologies. Yes. Also the new young physicians, I noticed they interested in new technologies, and also there is a lot of young lady doctors. I think they are mostly radiologists.
Yeah, that's right.
That's why it's noticeable, because the gender equality is one of the key questions nowadays.
That's true. And you come from a neurosurgeon background, don't you?
Yes, I started my medical academy at that time. Now it's a university in Kazakhstan, in Karaganda city. And during my medical education, I noticed that the neuro system is unique, and it's quite hard for the other students to study the neuro. That's why I choose
You mean neurosurgery or neurology?
The neuro system.
The nervous
the brain,
system,
the spine, and the nerves. It's very complex. That's why I decided this is my future profession.
So you like more complex stuff. You like
then less competition.
Less competition.
Yes.
That's true as well.
Yes. And during the 7th course, which were the internship, I went to the neurosurgery, and during the neurosurgical internship, I started to do diagnostic direct carotid puncture and angiography. At that time in Kazakhstan, it was limited number, only 2 machines for MR.
All across Kazakhstan.
All across the Kazakhstan. Okay. That's why we should do for the emergency cases to do diagnostics, the diagnostic angiography.
And at the time, as I realized, because I did a lecture about that, they used to do the cut down. So you open the skin?
No, it's a direct.
You just do
direct puncture.
Yeah, okay.
Through the skin.
Through the skin, that's true. Okay.
And then with the presidential program Bolashak, I went for the residency in Russia. I studied 2.5 years in St. Petersburg in Military Medical Academy.
Okay.
And mostly I focused on spinal surgery because my teacher was mainly spinal surgeon. But I said him, I want to deal with the vascular pathologies. I want to do endovascular, and he said this technology is very expensive, and at the 2006-2007 it was no angiography suites for the neuro.
Okay.
And I said, okay, maybe one day I will do it. In 2008 I graduated my residency, and I came back to Kazakhstan, and I went to neurosurgical center. It was brand new. And I came to the chief of the hospital, and he said, okay, spinal department is full. There is no vacancy. And he sent me to vascular and functional neurosurgery department.
Perfect.
And it was the first neuroangio machine in Kazakhstan.
All over Kazakhstan.
Yes.
Perfect. Okay.
That's why I started to do diagnostic angiography there. And then my teacher, Dr. Shimon Maimon, he's Israeli from Tel Aviv. He started to come to the department, and we did the cases together. And I really interested in endovascular. We call it endovascular neurosurgery because we started in neurosurgical center. But all over the world, it's interventional neuroradiology.
Yeah, that's true. Yeah. Okay, perfect. And do you remember one case that would showcase what is a neurointervention? What do you usually do?
Yes, in 2013, I did the first mechanical thrombectomy in the country.
Perfect.
In 2015, the Mr. Clean trial and the other trials made the mechanical thrombectomy as a gold standard. But at that time, it was out of indication. It was just the exceptional treatment. The IV thrombolysis was the standard. But
that's true.
Then mechanical thrombectomy came.
Can we explain what is mechanical thrombectomy?
Mechanical thrombectomy is access through the arteries. It could be femoral artery in our practice, and nowadays it's a radial approach.
That's true.
And you're going to the brain vessels and doing diagnostic, and when you see the thrombus in the artery, you just go and take out with the stent retriever at that time. But nowadays you can combine aspiration, and if it's not effective, you can do both.
So you go through from the inside of the vessel, and once you meet the thrombus,
without craniotomy.
Yeah, without opening the skull. That's true.
In many cases, it's under local anesthesia.
Yeah, that's true. And then you either aspirate the thrombus, or you have a stent retriever, which is like a basket.
Yes,
now you combine.
But in 2013, the treatment was done with the solitaire stent, which were designed for the remodeling technique for the aneurysm. And in Kazakhstan, it was a history why we started to study the mechanical thrombectomy in 2010. Together with my teacher, Dr. Shimon Maimon, we did a treatment for the MCA aneurysm. It was an elective case, and in left MCA territory, wide neck aneurysm, we placed solitaire stent for the remodeling, and then placed coils. And at the end of the procedure, we have seen that the small clot moved from the guiding catheter and blocked the stent. In 2010, nobody knows that the solitaire stent could be used for the
to do the thrombectomy. Okay, the irony of it. Okay.
We tried to thrombolyze with the streptokinase, but it was not effective. Then we crushed the thrombus with the balloon. It was not effective. And finally, patient developed MCA territory stroke. And in 10 days, patient passed away. And it was very
disheartening for you. It affected you. Okay.
Hurted me. And I promised myself that my next patients will never have a
similar condition,
similar complication. If it would be thrombus, I will take it out.
Okay, perfect.
That's why in 2012 I went to Jerusalem. I was in Hadassah Hospital together with Professor Jose Cohen, and then he suggested me to go to Essen to Professor René Chapeau, and I stayed another 3 weeks with Professor René Chapeau, and he already done a couple of ELIS courses. And in 2013, I went for the next ELIS course where I met
Dr. Ahmed
Ahmed El-Servi.
Okay. Perfect.
It's a long history, yes.
Yeah. Okay. And how do you think, being a neurosurgeon who were introduced to the vascular or endovascular interventions, how do you see the combining? Do you find it a bit conflicting? Do you find it like an addition?
I think for the interventional neuroradiologist, it's all the time a little bit complex, because a patient first line coming to neurologists and neurosurgeons, and then they gives the patient for neuroradiology in most of the countries. If the vascular neurosurgeon very powerful, then most of the treatment is microsurgery. If the interventional vascular neurosurgeon don't want to deal with the vascular pathology, then interventional neuroradiologists are happy. In our country, we came from the neurosurgery. That's why we are deciding which patient will go for the endovascular, and which patient for the
and go for the open surgery.
Microsurgery.
But what do you think of the endovascular in general in comparison to microsurgery? Is it always better? Is it?
No, it's not always better. There is no universal treatment. That's why the both modalities are existing. The microsurgery, in some cases, it's the best option, and the endovascular treatment, in some cases, is the best option if there is a mechanical thrombectomy for stroke. There are limited experience with the bypass, and not so many specialists doing very quick bypass. That's why the endovascular treatment is the first line treatment. And also for the cavernous segment, nowadays there is no microsurgery. Most of the arteriovenous malformations done by the endovascular, dural fistulas, and nowadays we're treating more and more brain tumors like meningioma, and it's endovascularly under local anesthesia.
So which embolic do you use for the meningioma injection?
We use the liquid embolics. And mostly we use liquid embolic for squid 12. Yes, it's less viscous. It's very nice visible. And
do you later on do a surgery? Is this a preoperative endovascular intervention?
In half of the cases, we don't touch the patient.
Really?
Without craniectomy, the tumor is resolving. Yes. And in 25% of all embolized cases, tumor is disappearing.
25%? Have you published a paper with that?
The paper is on the way.
Really?
Yes. We joined
really
the international data together with US colleagues, some colleagues from Italy, European colleagues and Indian colleagues, and a colleague from Russia. We collected all data and MR before, after, and angiographic images. And I hope it will be published in a couple of months.
Excellent. We're really looking up to it. But then you would say that the endovascular management is better than surgery, isn't it?
Not in all cases, but it could be a good alternative.
Yeah, okay, that's fine. I think I'm out of questions. Is there another topic that you would like to talk about?
I want to wish to Egyptian society and personally to my friend Ahmed El Servi and Farouk Hassan, Mustafa Farid, great success in this field. And as I said, Kazakhstan is a small country, just 20 million population with wide territory. It's less than population of Cairo
alone.
And they're happy. They're living in a most densely populated city. But I wish the health to the Egyptian population.
Yeah, thank you so much.
Yes, but the other side of the healthy life is a long life.
Of course.
When the population start to live longer, one day they will have a stroke because of the long life. Yes,
Okay.
I think the stroke in 90s, in 100 years, it's not bad.
It's not.
It's not bad. Yes.
Okay, absolutely. It's an absolute pleasure to have you, and we wish to see you a lot in the future.
Thank you.
Thank you. You're welcome.